Hello, everybody. I'm Laura O'Reilly, the Executive Director of the North Jersey Health Collaborative. Today, I present Mary Ellen Zung, Certified Holistic Health Coach and Health Educator for our ScreenNJ Cancer Prevention and Education and Detection Series for the North Jersey Health Collaborative. Thank you, Mary Ellen.
Thank you, Laura, and I want to thank everyone for taking the time out of your busy day for this webinar about healthcare and cancer screenings for those with intellectual and developmental disabilities. Our focus today is on colorectal cancer screening for individuals with intellectual and developmental disabilities, but we'll also discuss other cancer screenings and the overall healthcare landscape for those with IDD. We know that all people benefit from receiving appropriate support, information, and resources aimed at preventative healthcare and early detection cancer screenings. Ensuring people with disabilities have availability to these services speaks to the health equity goals of the Convention on the Rights of Persons with Disabilities that recognizes that people with disabilities have the right to achieve the highest attainable standard of health without discrimination on the basis of disability. So to be sure, people with disabilities may have health concerns that require a provider look more specifically at disability-related health. But this shouldn't come at the expense of getting regular cancer screenings, as these offer the best chance for survival through early detection and treatment. People with disabilities should not be denied access to these potentially life-saving screenings. Approximately 61 million people, nearly 26% of the US population, live with some type of disability, so about 1 in 4 people in the US. The definition is a person who has a physical or mental impairment that substantially limits one or more major life activities, a person who has a history or record of such impairment, or a person who is perceived by others as having such an impairment. And just to be more specific, there are 6 million people with intellectual and developmental disabilities. So the term developmental disability means a severe chronic disability of an individual 5 years of age or older that is attributable to a mental or physical impairment or combination of mental and physical impairment. It's manifested before the individual attains age 22. It's likely to continue indefinitely and results in substantial functional limitations in 3 or more of the following areas of major life activity: self-care, receptive and expressive language, learning, mobility, self-direction, capacity for independent living, and economic self-sufficiency. And it also, the definition reflects the individual's need for a combination and sequence of special care. We know that individuals with disabilities have a higher risk of developing chronic health conditions at younger ages than other adults due to biological factors related to syndromes and associated developmental disabilities, problems with access to adequate health care, lifestyle and environmental issues, as well as socioeconomic and other barriers to care. And in addition to these functional disability types, from mobility, cognition, ability to live independently, hearing, vision, and self-care, such as dressing and bathing, people with disabilities often are at risk for, or greater risk for, health problems that can be prevented. As a result of having a specific type of disability, these secondary physical or mental conditions can occur. Bowel motility, which of course is a risk for colon cancer. Bowel or bladder problems. We know this gets very complicated when managing the prep for colonoscopy or even a Cologuard test. Fatigue, injury, mental health and depression, overweight and obesity, pain, pressure sores, or ulcers. And those with disabilities have higher rates of obesity than those without disabilities. They also smoke at higher rates, have heart disease and also have diabetes at higher rates than those without disability. We know the risks of smoking related to cancer. Cigarette smoking causes cancers of the bladder, oral cavity, larynx, esophagus, cervix, kidney, pancreas, stomach, and lung. And smoking approximately doubles the risk for stroke and increases the risk of peripheral vascular disease and chronic obstructive pulmonary disease by more than 10 times that of a non-smoker. The most common causes of death among individuals with IDD are cardiovascular diseases, respiratory illnesses, tumor growth, and all of these conditions can be influenced by smoking, even secondhand smoke. These lifestyle risks can lead to higher rates of heart disease, diabetes, and cancer. We know that a healthy diet that regulates weight can help reduce cancer risk. Fat tissue causes inflammation in the body, increasing the risk for cancer. And when it's around the organs, it can increase the risk for breast, endometrial, liver, and pancreatic cancers, among others. People with disabilities can find it more difficult to always eat healthy and control their weight. This might be due to a lack of healthy food choices, difficulty with chewing or swallowing food, which can lead them to eat softer, more processed, and frequently less nutritious foods, or with the taste or texture of foods. Medications can contribute to weight gain and changes in appetite. Intentional weight loss, we know, has been seen to reduce cancer risks as high as 78%. However, weight loss with people with IDD is very challenging for many of these reasons. And lack of activity is another challenge relating to weight control and obesity. In New Jersey, 44.3% of people with disabilities are inactive, compared to 26.2% of people in New Jersey without disabilities. We know there are so many benefits to getting exercise. Physical activity is good for your heart, mental health, and it helps reduce obesity, cancer incidence, and tumor growth. And physical limitations that can reduce a person's ability to exercise. Physical and mobility limitations, pain, a lack of energy, a lack of accessible environments, lack of resources, and need for modifications and costs of specialized programs. These are some of the healthcare access barriers for adults with disabilities. 1 in 3 do not have a usual healthcare provider. And for many with IDD, their primary doc is a neurologist trying to manage anti-seizure medications or other specialists. They are not thinking of preventative healthcare, and they don't go over or ask about health history or cancer screenings. The cost of care can be a barrier. 1 in 3 people with individual and developmental disabilities have an unmet healthcare need because of cost in the past year. And in New Jersey, 25.9% of those with disabilities couldn't see a doctor due to cost versus 8.6% of non-disabled adults. And 1 in 4 didn't have a routine checkup in the past year. And there are other healthcare barriers to healthcare, such as transportation, not understanding why a test is needed, not knowing family history, lack of an advocate, fear of anxiety, complexities of insurance and paperwork, physical challenges to perform a test. And cancer screening is so important because we all know that early detection of cancer leads to better outcomes. Here are the screening guidelines from the American Cancer Society. Cervical cancer screening beginning at age 25, and then every 3 years until age 65 or until you don't have a cervix. Breast cancer screening is recommended beginning at age 45 with the option to begin at age 40. And the recommendation is to continue to have a breast exam until age 55 and then every 2 years. Colorectal cancer screening is recommended for everyone beginning at age 45. And if family history, then earlier. Since 1 in every 10 cases of colorectal cancer occur in individuals in their 40s, it's important to start screening at the age of 45. Screening should continue at regular intervals until the age of 75. After that time, a process of shared decision-making between a patient and provider should take place, and that weighs the risks versus the benefits. At age 45, African Americans should discuss prostate cancer screening with the doctor, and at age 50, people who currently smoke or formerly smoked should discuss lung cancer screening with a doctor, and discussing prostate cancer screening with a doctor is also recommended. So let's look at this cohort study of cancer screening incidence rates among one cohort with intellectual and developmental disabilities compared to another cohort of adults without disabilities. We can see from the chart that adults without disabilities are being screened for colon cancer 48 times higher than adults with disabilities. And for breast cancer, women without disabilities are being screened at 60% higher rate than those with IDD, more than double the rate, according to this study. Why is this so? We've touched on some of the barriers to healthcare. Let's look at the barriers to cancer screening in particular. There are practical barriers, including mobility, as well as difficulty understanding literature and using appointment systems. Communication barriers include inappropriate stereotyping. In one study, communication barriers were identified by healthcare professionals as one of the most significant barriers to breast screening. And it goes both ways. Providers reported feelings of uncertainty when discussing cancer screenings with their patients with disabilities, and patients with disabilities also felt they were not getting enough consistent information about cancer screenings. They weren't sure why they should receive the cancer screenings, how to prepare for the screenings, and the logistical process of the procedure. Attitude and knowledge of professionals, support services, and family caregivers is a barrier. Research suggests that there's a need for more improved practical support and training for staff and family caregivers. And clinicians may consider a woman with disabilities to be at a lower risk of cervical cancer because they're less sexually active. They may also consider that disabled people have a relatively shorter life expectancy, and therefore cancer screening in this population may not appear to be beneficial. Provider level barriers such as negative attitudes, a feeling of discomfort, a lack of time, knowledge, or training are usually suggested as explanations for the lower use of preventative care among people with disabilities. So it's a vital component of patient-centered care, particularly toward people with disabilities, is to have empathy. For people with intellectual and learning disabilities, they may not understand the importance of screening, while feelings of fear and anxiety can also be a barrier to participation. Depression is a barrier to screening. 30% of women with disabilities have clinical depression compared to about 8% of women without disabilities. And clinically depressed women have been shown to be less likely to have mammograms. So lack of intellectual capacity combined with common anxiety associated with the screenings creates a big hurdle for disease prevention and lowers screening adherence. Also, there's accessible information and resources for professionals, but many staff are unaware of the resources that are available. Adults with intellectual and developmental disabilities need to have a cancer screening just like everyone else. Colorectal cancer starts from a tissue growth that's initially harmless or benign. So the American Cancer Society estimates we have about 53,000 deaths in the US this year due to colorectal cancer. It can be one of the deadliest cancers, and it's the second leading cause of cancer deaths in the US. So for those with IDD, fear and the bowel preparation are the most reported barriers to colonoscopy screening. We know from reporting that if poor bowel prep occurs in up to, we know that from reporting that poor bowel prep occurs in up to 50% of IDD patients. And people with IDD need support to do the prep properly. Prep could be uncomfortable. They may not finish. If you're in a group home, you need to have staff to really be on top of the prep, making sure that the patient is hydrating. There could be adverse events such as nausea, abdominal pain, dehydration, and renal toxicity. PrEP has a lot of sodium, and the sodium imbalance can throw off the kidneys, and that could damage the kidneys. We know about colonoscopy, but there are stool-based tests that could be a lot easier for people with intellectual and developmental disabilities. These are good for someone who doesn't have a history of rectal bleeding. The fecal occult blood test is used to detect hidden or occult blood in your stool. And so this is just applying a smear of stool onto a card, and the lab applies a chemical to the card. If the card turns blue, the result is positive. And the FIT test, or the fecal immunochemical test, is similar to the fecal occult blood test, but it looks for antibodies to detect blood from polyps of cancer. And the multi-targeted stool DNA test, branded as Cologuard, that's where you're looking at the DNA to look at any altered genetic material from polyps and cancer cells. And of course, you'd want to follow up and get the test result. So work with your touch on some of the approaches the medical community can take to improve participation in screening programs. So there's partnership and coordination of resources, community learning team nurses and primary care staff, medical community support staff and caregivers. If we had easier access, such as telehealth, appointment availability, if transitions of care were coordinated. We know, for example, based on one study, that improved partnership working between community learning disability team nurses and primary care staff can help increase uptake of cervical screening by women with learning disabilities. Education and training, support for professional support staff and family caregivers. We know from research that training is essential for all key people, including these stakeholders, residential staff, general practitioners, radiologists. So to promote health and wellness, health agencies, providers, and plans must promote prevention and education programs that are inclusive and responsive to the special needs of people with disabilities. Cancer screening programs might require additional information, such as where to find screening sites, or health information might need to be presented in alternative formats, such as large print, Braille, or American Sign Language. Investigators found that spousal support played a significant role in improved cancer screening, knowledge, and adherence when compared with people with disabilities who were single or living with caregivers. Those with strong support systems, family or friends, reported better understanding of the importance of cancer screening and expressed more desire to engage in preventative health measures. Careful preparation with those with IDD is needed to empower patients. This can happen with training, education, support, and patient-focused goals to help people understand the need for screening programs and the processes involved. And these steps can increase the likelihood of a successful screening test. So in summary, disability is not an illness. Healthcare and screenings must be accessible to all people. Screening can and does prevent certain cancers and cancer death. And we must continue to work together to break down barriers to care for those with IDD. Here are some colorectal screening resources: ScreenNJ, the NJHC, the Cancer Education and Early Detection, and the American College of Radiology has a screening finder. And these are some additional resources for those with intellectual and developmental disabilities. The ARC of New Jersey is the state's largest organization advocating for and serving children and adults with intellectual and developmental disabilities and their families. You can go to the health and wellness section of the ARC of NJ website for 3 cancer prevention and screening booklets, really helpful. The adult medical record form in English and Spanish, and diabetes prevention booklets and videos in English and Spanish. And then the Disability Rights New Jersey advocates for people with intellectual and developmental disabilities, and their priorities are protecting individuals from abuse or neglect perpetrated by the guardian. And second is assisting individuals with disabilities to enforce their right to self-determination when they disagree with a caregiver. So that concludes this presentation. If you have any questions, please visit us at njhealthmatters.org and send us an email. Thank you.